Good morning to all of you. It's nice to be amidst you. Ever since von Graffi described this particular disease as lutic recurrent retinitis, central serous retinopathy has been known by different names, and lately central serous chorioretinopathy. It's a chorioretinal disease associated with systemic association with multifactorial etiology and complex pathogenesis. Gas described that increase in choriocapillary hyperpermeability was the main reason for CSR. This leads to a focal or diffuse dysfunction of the retinal pigment epithelium, which in turn leads to detachment of the neurosensory retina. Thus, we know that choroidal hyperpermeability is the first event in CSR. What causes this choroidal hyperpermeability is still not clearly understood. Few important associations are increase in the cortisol levels, type A behavior pattern. CSR is seen in some of the post-transplant patients as well, and familial cases have also been reported. Visual loss in central serous chorioretinopathy can be attributed to foveal atrophy, cystoid macular degeneration, damage of the foveal photoreceptor layer, and secondary choroidal neovascular membrane. Typically, a middle-aged old man may walk into your clinic with complaints of defective central vision, or he may complain of metamorphopsia, a central scotoma, or decrease in contrast sensitivity. Slit-lamp biomicroscopy is still the best method to identify a case of acute central serous retinopathy, and it may be seen as an area of elevated retina involving or not involving the foveal area. Sometimes you may come across fibrin which is located in the subretinal space, like this in case of acute CSR, and this clinically may give us a clue on the location of leak in these cases. Yet another case may show subretinal precipitates, as in this case. As the disease becomes chronic, as Spade et al. Rightly mentioned, that persistent fluid for more than 6 months with RPE alterations and a characteristic RPE tract. RPE tract basically seeps down the subretinal fluid to the inferior part of the retina, so you will not be surprised. In some cases we may come across an exudative retinal detachment associated with chronic central serous chorioretinopathy. Fundus fluorescent angiogram is important but not indicated in all cases of CSR. Fundus fluorescent angiogram helps us in differentiating CSR from other causes or other look-alike diseases, and it also helps us in identifying the area of leaks for treatment. As in this case, you can see a smokestack type of leak. Another type of leak is an ink blot type of leak. You can see that a slowly increasing hyperfluorescence, increasing in intensity as well as the size towards the later stages of the angiogram. The CSR has got widespread retinal pigment epithelial abnormalities in the form of window defects as well as a smokestack type of leak. This shows the chronicity of the disease which is still active. So this is a chronic CSR with an active leak. RPE tracts on FFA shows a window defects. In this CSR, we may see that there is fluid, yes, but there is no point leak like we saw in the previous slides. Here we have a diffuse pattern leak. This is because of a widespread sick retinal pigment epithelium. In this CSR, we may see multiple areas of point leak. We call this a multifocal CSR. This central serous chorioretinopathy has got subretinal fluid as well as pigment epithelial detachment associated with, which is so clearly seen in this fundus fluorescent angiogram. In the early stages of the angiogram, you see a hyperfluorescence which is increasing in intensity as well as increasing in size with fuzzy margins, denoting that this is a leak. However, this lesion shows hyperfluorescence increasing in intensity, but the size is almost the same. Thus, we know that this is a case of pigment epithelial detachment. Thus, pigment epithelial detachment and neurosensory detachment coexist in some of the cases. Indocyanine green angiogram helps us in delineating the area of choroidal hyperpermeability. This is a fundus fluorescent angiogram image showing the area of leak. Indocyanine green angiogram shows a different area of choroidal hyperpermeability. So you may come across an area of hyperpermeability which may not be corresponding to the area of leak. OCT or optical coherence tomography helps us in finding out certain subtle findings which you otherwise may not pick up on clinical examination, like in this case of a small pigment epithelial detachment associated with a neurosensory detachment which we may not pick up on direct clinical examination. Specular domain OCTs have actually found out micro rips in the retinal pigment epithelium which is responsible for the neurosensory detachment. Thus, this gives a volumetric analysis of the disease as well as it helps in following up these patients. Autofluorescence may show increased hyperautofluorescence in the early phases of the disease, and later on there may be a granular or confluent hypofluorescence which denotes widespread RPE atrophy. The natural history, we all know it's quite fair, and many cases come back to the normal vision after the initial episode. However, one need to notice that the quality of the vision is affected in the form of defective color vision as well as contrast sensitivity. This case shows a leak at the center part of the fovea, but it isn't as intense as what we saw in the previous slides. This is probably a spontaneously resolving central serous chorioretinopathy. We have a huge list of differential diagnoses for this disease, but I would like to draw your attention to vascular disorders, namely malignant hypertension and toxemia of pregnancy, which causes choroidal infarction, which cause serous detachment of the macula. So these entities has to be differentiated from central serous chorioretinopathy. Initial examination, I would diagnose this as a case of CSR with fibrin deposition. However, if you do an angiogram, you can see early hypofluorescence in the early phase of the angiogram followed by later leakage, as well as a disc staining which denotes an inflammatory component to this disease. This is a case of macular choroiditis. Harrod's disease, otherwise known as Vogt-Koyanagi-Harrod's disease, it's also a look-alike disease with central serous chorioretinopathy. But here you can see again there is disc staining as well as pinpoint hyperfluorescence which increases on the later stage of angiogram. If you do an ultrasound B scan in these patients, you may see an increase in choroidal thickness. Yet another look-alike disease is uveal effusion syndrome. Here the primary pathology lies in the thickness of the sclera. Sclera is so thick which can be clearly seen in this ultrasound B scan. Thereby there is venous congestion and which causes serous macular detachment. Yet another look-alike disease is posterior scleritis, which will have an inflammatory component like Harrod's disease, but the patient may complain of painful ocular movements, as well as if you do ultrasound B scan, you may see posterior subtenons widening, known as the T sign. Many of the ocular tumors may resemble central serous chorioretinopathy. This is a circumscribed choroidal hemangioma with subretinal fluid. But here you can see the reddish orange hue given by the tumor which differentiates from CSR. This is a fairly straightforward diagnosis of a button collar choroidal melanoma, but when the melanoma is in the early stage with serous detachment, one may confuse it with a CSR. And ultrasonography can clearly differentiate this from a CSR. This is a maculopathy with optic disc pit, which can also be a differential diagnosis. This is yet another case of serohemorrhagic pigment epithelial detachment, which shows late filling of the pigment epithelial detachment, which shows that this is not a CSR. Choroidal neovascular membranes, especially the idiopathic variety, may have a simulation to a CSR, but fundus fluorescent angiogram helps us in delineating this. Polypoidal choroidal vasculopathy is yet another differential diagnosis for CSR. You can see multiple polypoidal lesions here, which can be confirmed by using an indocyanine green angiogram. Thus, when to treat a case of central serous chorioretinopathy? If it's a first attack, you may wait for up to 3 months to see whether there is spontaneous resolution, because we know the natural history of the disease is quite good. But if it's not resolving for more than 3 months, and if there is a chronic CSR with present activity, permanent visual loss in the fellow eye due to CSR, then you may have to intervene early. Treatment options include observation, focal laser to the leaks in case the leaks are a little away from the fovea, otherwise you may damage the fovea with laser burns. Photodynamic therapy has been internationally accepted now as a standard of care in the management of central serous chorioretinopathy. Either a low fluence or half-dose vertiporphin therapy has been accepted by many. Micropulse laser would be the laser of the future, as it gives advantages of conventional laser with minimal collateral damage. VEGF antagonist and corticosteroid antagonists have also been tried in the management of this disease with variable results. Last but not the least, the patient should be clearly mentioned about the role of steroid in this disease, and if he is using steroids in any forms, it has to be stopped. And he should also understand the role of stress in the pathogenesis of this disease. Thank you.